So I'll be talking today on CAR T cell therapy in B cell lymphoma and CLL. As many of you may already know that this is a treatment that has, significantly changed the treatment algorithm for many diseases, but in particularly lymphoma as well as CLL. So we'll talk about the evolution of this treatment, where it's applicable today, which particular lymphomas it's FDA approved in which clinical settings, and then we'll also talk about the very important aspect of toxicity as well as other challenges. So as I mentioned, we'll be moving through all of these things throughout the course of our time today in terms of the indications, the efficacy, curative potential, challenges, toxicity, as well as how does life look like for a CAR T patient in terms of our survivorship, because all of these treatments, they come with, significant while they're very effective, there's also significant burden that are associated in terms of how you manage your life afterwards, burdens for caregiver, and several aspects that are intricately related to these effective but complex treatments. So, what exactly is CAR T cell therapy? So, if you look at it in a very simplistic and basic manner, which is how we want to do it, is that it is a treatment where your own T cells are genetically engineered by attaching an artificial antigen receptor. And as a result of the attachment of that receptor to your T cells, that is what in fact leads to the development of CAR T cells. And if you look at CAR T cell therapy, it's a long work in progress. And as you can see on the slide over here, starting in early 1990s, is when this work started. And it took over almost close to 3 decades when we first saw the first FDA approval of a CD19-directed CAR T cell therapy, with the first indication being in acute lymphoblastic leukemia and non-Hodgkin lymphoma. So as I just mentioned, CD19, let's dissect that a little bit. So CD19 is a B cell surface protein that is expressed on your tumor cells. So in all B cell lymphomas, this marker is very uniformly and consistently expressed. And in CAR T cell therapy, one of the main things is one of the starting points and very important point is to identify a target, against which those T cells are going to go and attack. So it is very important when CAR T cell therapy was being developed to find a consistent expression of an antigen or a marker where these T cells, when they are genetically engineered and made into CAR T cells, can go after. So CD19 is that marker, in fact. And as noted here, it's expressed in all of these B cell malignancies, be it CLL and non-Hodgkin lymphoma. And therefore, all the currently FDA approved CAR T cell therapies are targeting CD19. Now, with that said, that doesn't mean that this is the only target. There can be other targets, and many other targets are being explored. But just so that we're, aware that all of those other targets are currently in clinical trials. As far as we currently stand, FDA approval is still restricted to CD19-directed therapies. Now, what can a patient expect, once he or she is determined to be getting CAR T cell therapy? So the first step is usually obviously meeting a physician, in a place that offers CAR T cell therapy. But once it is determined that you are a candidate for CAR T cell therapy, patients have to undergo a process, which shown over here is called as apheresis, where their T cells are removed from them. And that is why CAR T cell therapy is called as a personalized type of therapy, because each person's CAR T cell therapy is different from the other, because it is your own immune system that is being modified to attack the cancer. And then these T cells are then sent to a manufacturing facility where they are transduced with a retroviral vector that encodes that CAR, or the chimeric antigen receptor, which we talked about just a bit ago. And that leads to the transformation of those T cells that were removed from the patient to the CAR T cells. It takes about anywhere from 3 to 4 weeks for this process to be completed, and then the CAR T cells are returned back to the patient. However, before patients can actually receive the CAR T cell therapy, they have to receive what we call as lymphodepletion chemotherapy, which is usually a combination of 2 chemotherapies that are delivered at lower doses. And the purpose is to induce a bit of an immune suppression in the host, so that the CAR T cells can expand well and effectively effectively kill the tumor. So, which patients are really, indicated today to receive CAR T cell therapy? So, as you can see over here on the slide, there are multiple indications that for which in the field of lymphoma and CLL where CAR T cell therapy is approved. So, we'll go spend a little bit of time here. So, when we talk about large B cell lymphoma, that is actually the most common B cell lymphoma, and that is where CAR T cell therapy was first improved at the third line, meaning you had to fail 2 lines of different kinds of therapy to be able to get CAR T cell therapy. So we currently have approval of 3 different CAR T products in the third line for patients who have large B-cell lymphoma. As we're going to see in a few slides later, these 3 products were later investigated for patients who relapse early. This is, what is consistent in the field of oncology, that we try to move our effective treatments earlier. And that is our consistent theme because we want to cure more patients early on. So all of these therapies, these 3 CAR T cell products were moved in the second line. And as a result of those studies, 2 of them were FDA approved. So for large B-cell lymphoma, we can receive CAR T cell therapy in the second line as well as in the third line. Moving on to follicular lymphoma. Now, follicular lymphoma is the second most common follicular lymphoma after large B-cell lymphoma, but it's also one of the most common slow-growing lymphoma. So it's it has a lot of prevalence, follicular lymphoma. So it's obviously CAR T cell therapy was subsequently investigated, and 2 of the CAR T cell products are approved for patients who have failed 2 lines of therapies, and that is Axi-cel and Liso-cel. We'll talk more about these CAR T cell therapies by themselves in just a bit. Mantle cell lymphoma is another form of B-cell non-Hodgkin lymphoma, although not the most common, represents about 15% of all non-Hodgkin lymphoma. And here too, we have FDA approval for Brexucel and Liso-cel. So 2 CAR T cell therapy products approved here as well in the third line. And then more recently, we've had approval in CLL, which of Liso-cel, which is the only CAR T cell product that is approved for CLL. And it's notable to see that Liso-cel, which is lisocabtagene ciloleucel, manufactured by Bristol Myers Squibb, is approved for 4, indications across lymphoma and CLL. Now, beyond lymphoma, that's not the focus of our talk today. CAR T cell therapy is also approved in multiple myeloma as well as B-cell ALL. Now we're going to talk a little bit more about, the individual CAR T cell therapies and the individual diseases. Now, when we talk about large B-cell lymphoma, as I just mentioned, it is our most common most common lymphoma. So obviously, effective treatments were very much needed in this space. And why were they needed is what we're showing over here. As you can see, that patients, when disease comes back after their first line of treatment, now we can roughly cure about 60% of patients with frontline or first line treatment with DLBCL or large B-cell lymphoma. So as you can see, that still leaves around 40% of patients that are in a desperate need for additional treatments and cure. And before CAR T cell therapy, you can see that patients, especially if they were previously received rituximab, which is now very much the standard, their outcomes were very poor, especially if their disease came back within the first year. And in the second curves that are shown here from the SCHOLAR-1 study, what you're saying is this, that patients whose disease either didn't respond to frontline treatment, or their disease came back after 2 lines of treatment, or their disease came back in less than 12 months, they had a very poor outcome. So median survival was just in the range of 6 months. So it's important to understand this data because CAR T cell therapy was specifically made and approved for this patient population. Because really, before that, this is what we were looking in terms of outcomes. So 3 CAR T cell therapies as a result of these 3 respective trials shown here, the ZUMA-1, Transcend, and Juliet, were investigated as a separate. These were all investigated in separate clinical trials. So they were not head-to-head to each other. They were not compared to each other. But now we have long-term follow-up, and you can see that while, in the past, those 40% that we couldn't cure, pretty much everybody would experience a poor outcome. Out of those 40%, at least close to 40% of those patients are being rescued and are able to live 5 years. So we're now, somewhat confidently able to say that CAR T cell therapy is potentially curative, where we might, while we're still not, there's still room for improvement. We're not able to cure all patients, but in those patients who were previously able to just live up to, we were able to give them an estimate of 6 months, half of them are able to go on and lead healthy lives. So that was obviously a huge improvement from where we were. So highlighted over here, as you can see that that plateau is being achieved. That is, as I was mentioning, highlights the curative potential of CAR T cell therapy. Now, as I previously mentioned, as is customary in oncology, that we want to move our most effective treatments to the front, these three CAR T cell therapies that were approved in the third line were investigated in the second line. And in the second line, our standard historically before CAR T cell therapy made space in the second line was autologous transplant. So these three CAR T cell products, namely axi-cell, lyso-cell, as well as tisa-cell, were investigated in separate clinical trials against salvage chemotherapy and autologous transplant. And what was resulted was this, that axi-cell and lyso-cell were superior to chemotherapy and autologous transplant, which was our standard in the second line. The third CAR T cell therapy, tisa-cell, which I'm not showing over here, did not show superiority in the second line. So as a result, was not FDA approved. So for practice point, for patients who are transplant eligible and they relapse early, CAR T cell therapy is preferred as a result of these studies over our historical treatment of salvage chemotherapy and transplant. So expanding a little bit in terms of, especially in the second line, which patients, really benefited and which patients were really included in these trials. So I'm here showing you here data from those three clinical trials where these CAR T cell therapies were in the second line. And you can see that most of the patients over here were those who were refractory to frontline treatment or had relapsed within less than 12 months. So what the point to highlight over here is this, that in the second line trials, they were heavily enriched for very patients who were essentially resistant to chemotherapy. Again, the same concept is illustrated over here, where you can see, if you look at the axi-cell and tisa-cell and lyso-cell columns over here, you can see that 74%, 66%, 73% were refractory to frontline, highlighting that patients who relapse early are inherently chemo-resistant. And that was the issue before CAR T cell therapy, that we really just had chemotherapy as our treatment, what we had in our, as in the main treatment tool that we had, and it was inherently ineffective because these patients did not respond to chemotherapy. So responses, as you can see, which were clearly superior with axi-cell against standard of care CAR T cell therapy in the ZUMA-7, as well as the Transform, negative for the Belinda, leading to FDA approval of these two CAR T cell therapy in the second line as well. So here I'm showing you data again from the ZUMA-7 study, where you can see that axi-cell the curve is lying above our standard of care with a median survival or event-free survival of 8.3 over just 2 months of salvage therapy. This is the Transform showing lyso-cell, again, also showing similar results. And then Belinda, which is where you can see the curves are overlying, and as a result, did not show its efficacy in the second line and subsequently was not approved. Let's talk a little bit about CLL. This is one of our more recent indications for CAR T cell therapy. So we kind of captured our large B cell landscape, and then we'll talk a little bit more about toxicities and come back there later. But talking about lyso-cell, it is the first CAR T cell therapy that's approved in CLL and SLL, and it's also one of the most recent indications back in 2024. So in order to receive CAR T cell therapy in CLL, you have to have at least 2 prior lines of therapy, including what we call as BTK inhibitors and BCL2 inhibitors. So this approval was as a result of a phase 1/2 study, including around 117 patients. Overall response rate was 45%. And median duration of response was reaching 35.3 months. And deep remissions were achieved in 100% in the patients who did achieve a complete response. They were 20%, but very deep remissions were achieved. It's interesting to note over here that toxicities, which we'll talk in a little bit, were at 85%, and neurological events, which is the other aspect of neurotoxicity or toxicity from CAR T cell therapy, was 45%. So it's a one-time therapy offering durable and treatment-free remissions after failing two very effective lines of treatments in CLL, the BTK inhibitor and BCL2. So obviously it has been a great achievement and improvement in our patients with chronic lymphocytic leukemia. Moving onwards, follicular lymphoma, which, as I mentioned, is our second most common lymphoma and the most common indolent or slow-growing lymphoma. Uh, the same CAR T cell therapies, as I mentioned previously, CD19 expressed on all B cell non-Hodgkin, so it's obviously made scientific sense to explore these CAR T cell therapies in all of these histologies separately. So ZUMA-5 investigated axi-cell. You can see here highlighted that patients who received CAR T cell therapy in this trial were heavily pretreated with previous 3 lines of therapy. And you can see that despite being heavily pretreated, they had very high response rates of 92% with a complete response rate of 76%. And ILARA is where T-cell was investigated. And here too, you can see it's very similar high efficacy shown with previously heavily pretreated. And then Lysocell, that is the third CAR T cell therapy, which we have currently approved, available for other B cell non-Hodgkin lymphomas, was also investigated in follicular lymphoma in what we call as the Transcend study. And here too, you can see that response rates were in the range of 97%, CR rates of 94%. In the trial, they also included patients who were second-line follicular lymphoma. There is a subset of patients with follicular lymphoma who relapse early, and these were included in the clinical trial. And here, 2 high responses were seen. However, FDA has only approved CAR T cell therapy for patients with follicular lymphoma who have failed 2 treatments. So that's kind of a recap of where CAR T cell therapy is FDA approved, where patients should be considered for these highly effective therapies. But how does in our real life, in the real world setting, how do we determine that these patients should be getting CAR T cell therapy? So previously, when we had autologous transplant, and even now when we do transplant, we obviously have to consider several things. We have to look at patient's age, comorbidities, and, really because of the stress that is understood that these treatments can put on a person and, what we know historically as non-relapse mortality, meaning dying as a result of receiving intensive treatments. However, what we've come to understand about CAR T cell therapy is that that same map that we had for transplant does not necessarily, apply to CAR T cell therapy. Because several real world studies have shown that chronological age, comorbidities, cognitive or functional impairments, as such, do not affect post CAR T outcomes. So, what we advise is that automatic exclusion of patients based on age and comorbidities not be done. So the same eligibility that we have for transplant is not the same as CAR T. At our center, we've done several patients in their 80s, offered them CAR T cell therapy, and we've had very good outcomes. Now, I couldn't say the same for transplant because, the stakes and the intensity of treatment is different. So we recommend that patients who are but there are patients who are at high risk, but that is why it is recommended that these patients be referred to a multidisciplinary clinic. And at risks is typically considered patients, those who are of higher age, their functional status is somewhat limited, they have multiple comorbidities, and so forth. Now, especially since, my understanding is we have patients and caregivers, and for us clinicians too, it's very important to understand that which treatments are better tolerated by the patient. So patient-reported outcomes, which we call as PROs, is becoming an increasingly important field in oncology and in particularly in lymphoma. So with Lysocell in the Transform study that I previously shared that led to second line, patient-reported outcomes, validated tools to measure those were incorporated to get an objective sense of how these treatments are tolerated by the patients. And as a result, you can see over here that patient-reported outcomes are much better with CAR T cell therapy versus the standard of care of chemotherapy and transplant, which showing that not just that these treatments are effective, they're also better tolerated and lead to improved quality of life for patients. Now, we talked quite a bit about the efficacy of CAR T, which indications it is improved. Now, we'll talk a little bit more about the limitations of CAR T. So, there are several limitations of CAR Ts, and we're learning and we continue to learn how to better manage them. So, there's definitely logistical challenges, as I mentioned, patient need to undergo collection. They have a waiting time period. During that time period, their disease may progress. And then CAR T cell therapy, most notably, is associated with two particular side effects that are well recognized now. One being the cytokine release syndrome, and the other being neurotoxicity. Now, cytokine release syndrome, it's the most common serious toxicity, and it's on a spectrum. It can range from a low-grade constitutional symptoms, which is fever, to a full-on life-threatening multi-organ dysfunction. Now, what is important to understand is that the onset of CRS is somewhat predictable because it tends to occur along with the expansion of the CAR T cells in a person's body. So it usually tends to occur within the first week and typically peaks within the first 1 to 2 weeks. Currently, when CAR T cell therapy was approved, it was concurrently tocilizumab, which is an approved treatment which blocks one of the cytokines or chemicals that CAR T cell therapy produces, was approved for management of CRS. And if that doesn't work, our second line treatment is using corticosteroids. As CAR T cell therapy evolved, there were many grading criteria that were developed. We won't be going that, but I would like to share that currently what most centers now gravitate to or use because of simplicity and the evolution of these grading criteria is the ASTCT, which is the American Society of Transplant and Cell Therapy, where you can see that fever, blood pressure changes, and use of oxygen are factored into grading the intensity of the CRS. When we talk about the treatment of CRS, it is really taking into account the grading, which is why obviously that is very important. Grade 1 usually relies on supportive measures such as, antipyretics, Tylenol. Grade 2 relies on fluids, tocilizumab, as I mentioned. Grade 3 to 4 is where you want to consider your ICU being involved, rely on steroids. And grade 4 or refractory CRS is where we kind of pivot into other drugs, which are technically not FDA approved. However, several studies have shown to be effective in high grade CRS, such as anakinra, which is a blocker of IL-1, and siltuximab. Now, we have known for quite some time that CAR T cell therapy can traffic into the brain, and that is why neurotoxicity is also one of the side effects of CAR T cell therapy. Now, often it occurs concurrent with CRS, but it can occur independently too. And here too, the symptoms range on a spectrum, ranging from confusion and disorientation to seizures and cerebral edema on the other extreme. And it's usually, again, biphasic, with the first phase happening with the first 5 days and the second phase happening in the later time. There's also delayed neurotoxicity that can happen in a few patients, that's the third and the fourth week. However, thankfully, it's not that common, but can still occur. And it's important to keep that in mind as well. For neurotoxicity, also, we're now currently relying on the grading criteria by the American Society of Transplant and Cell Therapy. And here we take into account, most importantly, the ICE scoring system. So this is a scoring of 10 questions. Each question gives you a point, as you can see over here, where orientation, naming, following commands, writing. And that leads to a certain grade, where if your patient is not able to answer any of these questions, then as a result, you have the highest grade for toxicity. So in our clinical practice, when patient gets CAR T cell therapy, we're asking them these questions every 3 to 4 hours to ensure that we're not missing the development of neurotoxicity. How do we manage neurotoxicity? So the main, you want to, when it's mild, you can consider some seizure prophylaxis, look at whether, make sure that there's no medications that can, adversely affect the nervous system. But as it progresses, the main tool that we have is to use corticosteroids, involve our neurology colleagues, and and then additional investigations to rule out other causes such as concurrent infections and so forth. But the main point is that corticosteroids are center for management of neurotoxicity. Now, lesser known, but as I mentioned previously, that late neurological toxicities can also happen. So it's important to keep that in mind too, as patients, are discharged from the hospital. That can arise several weeks after infusion, can present with more of a vague symptoms like weakness, confusion, coordination problems, and so forth. Now, previously, this is not updated over here, but previously there was a recommendation of not driving 4 weeks post infusion, but FDA and the REMS program has updated, and that kind of requirement has been removed. However, it is recommended that you keep individual patients can be different. So in certain patient, obviously, if they've developed high grade neurotoxicity, it will still be advisable not to be careful with that. Now, we talked a little bit about treatment, about prevention. There's not a whole lot of data and there's not a whole lot that we can do, but there are definitely things that we can do to prevent prevention, to prevent toxicity. One modality has been to give some steroids on the first day of CAR T cell therapy and the second and the day of CAR T, the first and the second day. Other than that, there are also studies that are happening that are trying to investigate prophylactic agents, but this is more in the setting of clinical trials. In our routine practice, we've also now considered giving most of our patients what we call as bridging therapy, meaning in the time period where their cells are collected and they're still being manufactured, we often consider giving patients some form of bridging therapy. And the idea is to debulk the patient's disease, as we've known now that increased burden of disease puts patient at increased risk of toxicities. Now, another less common and less understood toxicity is what we call as CAR-T HLH or macrophage activation syndrome that has actually been now renamed as immune effector cell associated HLH-like syndrome. Now, this syndrome can happen in the setting of infections or, as a result of other diseases, but we've come to recognize that it can happen as a result of CAR T cell therapy, where you're basically seeing a hyper-inflammatory syndrome as a result of CAR T cell expanding. And this can cause serious consequences and can lead to bleeding, organ dysfunction, and really multi-organ failure. So the treatment of this, to be honest, is not very well understood, but we really rely on corticosteroids and using, agents that are known to have immune suppressive capacities, as noted here, like anakinra, ruxolitinib, and epapalumab, which is an anti-interferon gamma agent. Now we talked about, the more, talked about toxicities in CAR T cell therapy, the CRS and neurotoxicity. But in theory, while they're not technically the most common toxicities. Now, they're the most serious toxicities, and they are the ones that we want to manage because not managing them can have serious consequences. But the reality is that the most common side effect after CAR T cell therapy is actually cytopenia. So it's very, very common for patients to develop low blood counts after CAR T cell therapy. So if you look at our clinical trials where CAR T cell therapy was investigated, you can see that neutropenia, anemia, thrombocytopenia were very common, 78%, 43%, 38%. And it's not, restricted to a particular disease, but has happened with all CAR T cell therapy. So it looks like that it is a side effect that is actually unique to CAR T cell therapy and occurs regardless of the disease. A term called cardiopenia has been coined, and that is really, low blood counts in the setting of CAR T. And in fact, what has been come to understand is that while CAR T cell therapy by itself can also suppress it, there are also many other factors that are contributing it. The lymphodepletion chemotherapy that patients get, the inflammation patients, it's been very well demonstrated that patients who develop high-grade toxicities are going to have lower blood counts after CAR T cell therapy because the inflammation suppresses the bone marrow. Infections themselves can suppress counts, and sometimes disease coming back can also. So there's multiple factors, and they all need to be considered when you are evaluating a patient who has received CAR T and now has low blood counts. This is a useful model that I found is in our literature, where you look at what time frame patients are. That helps you to understand and narrow as to what is the reason of them having low blood counts. In the first to 30 days, it's really if patients the neurotoxicities, the CRS, basically CAR T related factors are more likely to play a cause. Persistent cytopenias beyond that, then you want to look at other causes, infection, disease, has it come back? Is that the reason for low blood counts? Are they developing any other autoimmune phenomena? And then if CAR T cell therapy related cytopenias or low blood counts persist beyond that, then you probably want to consider doing a bone marrow, look into secondary malignancies and so forth. Although that is less common, as noted here, nearly 1/3 of patients can experience that as well. And then this duration of cytopenias, as I showed, is quite variable. In theory, most patients do recover their blood counts in the first 30 days, but it can linger on, as I showed, due to various reasons. And the longer they are, the greater the risks. What are the risks? Somewhat obvious, but we'll talk a little bit more. And these are mainly infections, transfusions, prolonged hospitalizations, and increased medical costs. A study here was done specifically to look at infections in patients, and you can see that about 36.5% of the patients develop infection, and they had a low absolute neutrophil count. And only 22% of patients in the recovered neutrophil count had recovered count in the infection group, as opposed to 70% in the non-infection group at day 90, which clearly shows you that recovery of your immune system or your bone marrow is directly correlated to your risk of infection. And when we talk about the causes of death after CAR T cell therapy, particularly, of course, dying as a result of disease coming back is a different bucket. But when we particularly look at cause of death from CAR T, in fact, it's not CRS and neurotoxicity which leads. This is, in fact, infection is the leading cause of CAR T cell therapy related death. And it has been shown that cytopenias, and I think the effect is largely due to the infection, has a direct impact on survival. And as patients who had higher grade 3 neutropenia or thrombocytopenia, they had worse overall survival as compared to those who did not. As we can understand, that has clear implications on healthcare costs, longer hospitalization, infections, and so forth. So as we've come quite some time now, since our first FDA approval, kind of reaching into 9th year of CAR T cell therapy, we've come to better understand the side effect of cytopenias and how to manage them. And the European Society of Transplant and Hematology have come up with a grading system, as well as there is another grading system that is called as CAR Hematotox that looks at what is your baseline hematopoietic reserve going before the CAR T, the level of inflammation and your neutrophil count, platelets, and hemoglobin. And then based on that, it can give us some understanding of which patient is likely to develop a more prolonged neutropenia or a more prolonged cytopenia. And that can help us in terms of how to manage that patient, in terms of, how to counsel that patient in terms of risk of infections, and, how to manage them with preventive antibiotics and so on and so forth. So the management of this kind of relies on supportive care. We often use what we call as GCSF, which is Neupogen or Neulasta, for the management of neutropenia to prevent infections. Generally, we wait until 14 days, before considering that. There have been some case reports that have been published that there are these if patients are low on, because as I mentioned, all 3 cell lines can be affected: your hemoglobin, your white count, and your platelets. And erythropoietin stimulating agents, thrombopoietin receptor agonists, and these are agents that are actually FDA approved for different indications, but studies have shown that they may be helpful in this situation as well when your bone marrow reserve is low after CAR T cell therapy. In rare cases, some people have had some of their own cells that were stored before perhaps they were going to go for an autologous transplant. And in a few case reports, that has also been used to allow their bone marrow to recover. But that is obviously very limited to patients who have some of their own cells that were stored. So as I mentioned, that if you use that grading system, which is now recommended to be used, more consistently, you can estimate or prognosticate that which of your patients are going to develop more high-risk infection. So patients who have that high hematotox score more frequently develop infectious complications versus those who did not have those. And that can allow us to use an approach for antibiotic prophylaxis and using, preventive antibiotics as a preventive strategies for those who have a higher risk score. And then Lastly, when we're, to want to capture all spectrum of complications from CAR T cell therapy is therapy-related myeloid neoplasms. We've known for many years that all of our therapies, be it CAR T cell therapy or chemotherapies, that can put additional stress and can lead to the development of second malignancies. That has also been shown to happen with CAR T cell therapy. However, thankfully, it's not too high. It's estimated to be around 5%. And as of this point, we are still not 100% clear whether it is the CAR T cell therapy directly, which can cause secondary malignancies, because as you've seen that most of these patients have received many chemotherapies before. So it's hard to separate out if those previous treatments or the CAR T cell therapy. Still, patients, who continue to have persistent low counts, 3 months after CAR T cell therapy, a bone marrow biopsy is prudent to look into other development of second malignancies. And then lastly, we talked a little bit earlier, wanted to touch about survivorship. Like, how does life look like for a patient who, let's say, has gotten the CAR T cell therapy, been monitored in the hospital or, outpatient setting for 2 weeks, and now, and they're kind of out of that window of CRS and neurotoxicity. So it is still recommended, that we have close outpatient follow-up at least for the first 30 days, relocate if you're not living close to an area that delivered you the CAR T cell therapy because of the possibility of late side effects and so forth. After 30 days, if everything is looking good, patients are often recommended to go back to their preferring provider and then return to CAR T cell therapy for, restaging studies. Usually we do the first restaging studies before we send them back because that is done at 30 days, but then have the patients return back at 90 days and then after every 3 months until they're at least 6 months out of the CAR T cell therapy. And then, as I mentioned, your immune system is profoundly affected by CAR T cell therapy, which, is less understood. Our focus usually most on the CRS and neurotoxicity. So we do not recommend that patients get routine antibacterial and routine antifungal prophylaxis, but it will be, tailored to each patient. If your white cell count has still not recovered, then it's recommended. But we do routinely recommend patients getting antiviral and anti-PCP, which is a certain kind of a fungal infection, to continue for that for anywhere from 6 months to 1 year, because despite your white counts looking normal after CAR T cell therapy, you are immune suppressed as the nature of the treatment. And then immunoglobulin, which are antibodies, which are produced by our B cells, because B cells are suppressed by CAR T cell therapy, that can often get low, and as a result, patient can develop respiratory infections. So it is also routinely recommended that patients be evaluated for the levels of immunoglobulin G and be replaced for that. And then lastly, vaccinations. If you look at our transplant patients or how we manage those patients, it's routinely recommended that 6 months they get a full vaccinations. For CAR T cell therapy, that is still not the guidance. However, we recommend that around at say 3 months or 6 month mark, patients be evaluated for their vaccine titers, because sometimes patients can lose some of the vaccinations because their immune system did undergo somewhat of a reset after CAR T cell therapy. And if they are missing titers for some of their vaccines, vaccines that you get as a child or growing up, it is recommended they get revaccinated to those. And with that, I would like to thank you all for your attention, and I'd be happy to take any questions.
Thank you so much for your presentation. I see that we have a couple questions in the chat.
Let me see if I can see them. Okay. All right. So the first question I see is that I have, sorry, where did it go? Okay. I have CD10 negative follicular lymphoma to 2 lines of therapy. I also have MDS and pancytopenia. Would these conditions preclude me from receiving CAR T cell therapy? So that's an interesting question, and definitely a bit of a difficult situation. So to that, I think, if you were really need to now, another thing to consider is this, that for follicular lymphoma, we also have many other treatments, right? So if you were to see a lymphoma specialist, they'll probably, talk to you about other treatment options too. But since we're specifically talking about CAR T, so I'll focus in that area. So I think first thing, being CD10 negative would not exclude you, because, CAR T cell therapy is targeting CD19. So as long as you have CD19 expression, being CD10 negative should not be a problem. Now, the MDS and pancytopenia are different issues. Now, obviously, as I just mentioned, the cytopenia risk for CAR T cell therapy. So in your case, I would definitely recommend, if CAR T cell therapy is understood to be the only treatment option that we have, uh, then you have a bone marrow biopsy. And if patients have a low-grade MDS or the cytopenias are very, like mild, I think in that case, it's not contraindicated. However, if patient has like a high-grade MDS, where or cytopenias that are severe, then I think in those situations it becomes more of an issue. And then probably other kinds of treatments that do not have that extent of cytopenias associated with it would be more appropriate to consider. So in bottom line, I think if you have mild MDS, that is not necessarily a contraindication to CAR T cell therapy, and CAR T cell therapy can be considered. The second question is, for secondary CNS, which CAR T is good to use? Now, that's also a really good question. Now, to be honest, I would say that no CAR T cell therapy is, good, or I would say there's no CAR T cell therapy that's necessarily shown to be very effective in CNS. Now, we do know that CAR T cell therapy does work in secondary CNS because of the ability of CAR T cell therapy to go into the CNS. So all of them work, it's just that what the studies, that the data that we have shows that the effectiveness of CAR T cell therapy in the CNS is not the same as that. Now, that being said, I think if you were to go at FDA labels, Axi-cel is the only CAR T cell therapy which recently had an FDA FDA label updated to include because of a single study, which in fact showed not too bad of an outcomes, especially in secondary CNS lymphoma. So it's the only CAR T cell therapy, Axi-cel, that has an FDA label for I'll take that. Actually, that FDA label is particularly for primary CNS lymphoma. And your question is secondary CNS. So to that, I would say that really, we cannot say which CAR T, in my practice, if patients have secondary CNS lymphoma, like I have a couple of patients at this point who were planned to go for CAR T cell therapy, and we've incidentally discovered secondary CNS lymphoma. We try to treat that secondary CNS lymphoma, get it under control, because we know that while CAR T works in CNS, it's not as effective as elsewhere in the body. And then we still try to take them to CAR T cell therapy. So bottom line is that it's an area where still more work needs to be done, and we don't have a great answer for that. Outpatient versus inpatient CAR T. So a lot of places in the country are doing outpatient CAR T. Our model over here at Mayo is more of a hybrid where, we keep patients 7 days in and then discharge them. But I think from my perspective, it's important to consider and look at your individual patient too. So I think while it's great to be able to offer outpatient CAR T, you want to consider the patient, right? I mean, if you have somebody who's 85-year-old, or the caregiver situation is not ideal, or the patient is, expected to have high-grade toxicities, then you want to keep that patient inpatient. I mean, so I think both of these models are still in place, and we're trying to offer patients outpatient for their own, obviously, feasibility, and also for decreased healthcare costs. What to expect when in hospital right after getting blood back on isolation? I'm not sure I fully understand, but I'm assuming that means that, when you get CAR T cell therapy. So, I mean, typically, patients for us, we typically, do allow them to have visitors and all. But as I mentioned, that immune suppression is a very common issue. So, some form of care, is recommended for patients who get CAR T cell therapy. My wife got infused 7 months ago, LYL314 trial, which I know every scan showed induction in the SUV, but this seems to be slower than other. So, I mean, I'm aware of that clinical trial. In fact, we have it over here as well. It's hard to say because, that's still a clinical trial, so we don't have, the full spectrum of data, but the preliminary data, some patients actually, I want to say that's not specifically in reference to this CAR T. In some patients, we do see that the response seems to evolve over time. There are patients who have a partial response at 30 days, and then it becomes a complete response. So I think it's early to say whether it's just it's something that is specific to the Lyell CAR T cell therapy, but we do see that responses to CAR T cell therapy can deepen over time. MCL recommendations, concerns. Yeah, I mean, mantle cell lymphoma, currently it's become pretty much our standard to offer CAR T cell therapy in third line. So we typically, if patients have received whatever frontline treatments, usually some form of chemotherapy with rituximab, and if they have received a BTK inhibitor and they have progressed after that, and then we are pivoting to CAR T cell therapy. So it's become pretty much like large B cell lymphoma. We don't wait a long time to offer them, CAR T cell therapy. Getting close to starting kite outpatient. I don't think so. I mean, most of these bicistronic CAR T like Lyell and kite, a lot of people are mentioning that their toxicities based on the preliminary data or the data that we have from their earlier trials seems to be low as compared to the single targeted CAR T cell therapies, which are currently approved and which we talked about. So I don't see any obvious concerns. So hopefully everything goes well. I'm still for 30 months of CAR T therapy at risk of recurrence. Okay. That's really good. I mean, if you look at the studies for CAR T cell therapy, most patients relapse within the first 6 months. So the relapses can happen later too. So being out of CAR T for 30 months is really in your favor. And while the risk of relapse, I don't think we can ever say zero for these diseases, unfortunately, but I think it's really low at this point. So that's really encouraging, I would say. And then yeah, my secondary stain is not a tumor, is floating. So this is probably what we call as leptomeningeal trial, a leptomeningeal, or what we call a CSF involvement that I've often happens in patients, going into CAR T cell therapy. Unfortunately, we do not have any clinical trials specifically for that, and that is kind of what I was, saying earlier. Is this that what we try to do in these situations that we try to treat patients, usually what we call as intrathecal chemotherapy, where we give chemotherapy directly into the CSF space and try to get rid of the disease, and then still go ahead with the CAR T cell therapy with the goal that the CAR T cell therapy is going to get into remission and prevent the disease from coming back. Unfortunately, for these situations, particularly, clinical trials are limited. And but a lot of clinical trials, like for example, some of the ones that are mentioned here, they do allow patients who have history of CNS disease, but it's treated to enter into clinical trials. So I think that can definitely be considered. Obviously in consultation with your primary oncologist, if they can treat the disease, get to show that the disease is in remission, then I think many of these clinical trials do allow patients with history of CNS disease that is treated and not active to be included. Getting CAR T therapy after first line of chemo, what needs to happen when I'm released to go home? So no, I mean, we cannot, that's something obviously patients often ask, so, I do not recommend that. I mean, we cannot live in an incubator and, we need to have some sense of normalcy around us too when we go back home and after these treatments. But, general caution is recommended. Obviously, you want to have a general cleanliness in the house, and, and, um, and the other thing would be to avoid risky things, and that is being in huge crowds, or having people over that are sick, or if you can avoid contact with people who are sick, and those are kind of for eating raw food, those kind of things. So that usually is enough to prevent any kinds of serious infections or complications. And generally, in terms of how long having a caregiver, our practice is usually 30 days, but obviously that can change, right? Some people may not fully recover for 30 days, so then those can change. But generally, if a patient is, their counts have recovered by 30 days, they're in remission, they're looking good. So it's more of, kind of going by the day. And after 30 days, usually patients are able to, we do not have any, strict recommendations that somebody needs to be around them 24 hours after that. Okay, I think that seems to be the last question.
Perfect. And if there are any more questions, please feel free to throw them in the chat. However, I do have a couple just housekeeping items to go through. If there are any more questions, please feel to put them in the chat. We do have some events coming up, including an Impact on GI Microbiome on Cancer Progression webinar on next Tuesday. And then starting the next month, September 1st, we will be having a monthly cancer financial Q&A, expert questions on your treatment costs and support questions. Just a great opportunity to ask questions that are a financial aspect. And then we will be having a September 2nd webinar as well, which kicks off our event series for Blood Cancer Awareness Month with HealthTree's connection with Clear and Kill the Clipboard, which is a project that we partnered with Clear and the government with. So we'll learn more about that during that event. However, if you would like to meet in person, our next Connect to Cures event is in Pittsburgh. If you would like to register for the free event, please scan the QR code. However, if you're not quite near Pittsburgh at that time, feel free to still scan the QR code and tell us where you are. We would love to have our next Connect to Cures event in your hometown. And then a thank you to everyone that came today. This is the email for our supervisor. A lot of you might know Hannah. She is currently out, but feel free to email our supervisor and he will be able to answer any questions that you might have, as well as any comments that you would like to have about this event. I do see two more questions in the chat if you feel like you would like to answer those, Dr. Iqbal.
Sure. Let me see. Well, I feel like I have a flu after the CAR T therapy. I would say a bit of yes and no. Patients. So when they have fevers, we talked about CRS. When you have your CRS, it's fever, and yes, it can feel a little bit like that. But once we kind of treat it, patients usually recover pretty quickly. So I guess you could say that there is some synonymity to that, but typically there's obviously no, respiratory symptoms. Patients usually feel like fever, achy, those are that, but you don't really have any respiratory symptoms unless you have developed a superimposed infection, which can happen. So it's also, our standard that when patients do develop CRS, because you can never tell 100% that, okay, it's the CRS, it's not an infection. So we do test everybody for infections as well at the same time. So there's some synonymity and some differences, as I mentioned. We did IT chemo several times. The cancer won't go away. So yeah, I mean, that becomes a very difficult situation. It depends upon what kind of lymphoma we're dealing with. If it is large B-cell lymphoma or mantle cell lymphoma, there's no standard here and there's no great option. Unfortunately, this is an area of need. The CNS lymphoma, especially which is refractory, which is the situation when you're in CAR T cell therapy, is BTK inhibitors are often used, acalabrutinib, pirtobrutinib, zanubrutinib. These are drugs that have penetration of the nervous system. So I often, for my patients, try to incorporate that, if possible, alongside IT chemotherapy. And if that doesn't work, then you use like other chemotherapies that are penetrate the nervous system, like high-dose methotrexate, cytarabine, and so forth. But unfortunately, yes, it is a very different situation, but those are certain things that can be used.
Perfect. Thank you so much. Do you have any parting words for us at the end of our event today?
No, thank you so much, and lots of good questions. So it was a very engaged audience. So thank you.
Thank you so much for coming here and sharing your knowledge with us today, and I hope to see everyone again soon.
Thank you so much.
Bye.